disease. Um, and the epidemiology was shaping out that ulcerative colitis was more common than Crohn's. Um, as time passed by, it was thought that it was a Western type of disease, but the incidence and prevalence of Crohn's disease and ulcerative colitis started to stabilize a bit. And what we see nowadays, since the 1990s, that industrialized countries, westernized countries, our area in the globe has seen more and more of ulcerative colitis and Crohn's disease, as opposed to our previous infectious type of diseases that we used to see in our populations. Especially, at least in Saudi Arabia, we had a lot of intestinal tuberculosis. And in year 2000, it was well recognized that inflammatory bowel disease is a global disease. It has a global footprint, and its incidence and prevalence has been more widely described throughout the globe. So let's look at the age standardized incidence rate, and that takes into account the population age pyramid. And when we neutralize all of that, we find that our area of the world, let's say at least in Saudi Arabia, we're around 30 to 40 cases per 100,000. This work has been published early this year. And I'll have to say it's done by the Global Burden of Disease Group. And this is a lot of modeling. There's a lot of assumptions. There's a lot of extrapolations. So this is anything but perfect. So we really don't know the exact prevalence or incidence, but we think that this is the closest we've been to an estimate that we have. So in areas like Libya, Saudi, Oman, we're something around 30 to 40 per 100,000 population as incidence. That's as a yearly occurrence of the disease. Well, in Egypt, Morocco, Algeria, Tunisia, Yemen, Sudan, it's much higher. It's almost double that. So we're talking about 60 to 70 cases per 100,000. But we're still far less below the hot spots that are happening in Europe, in New Zealand, and other places. So let's take a closer look. So if you look at the Arab world, you can see that, as I said, Egypt, Sudan, Morocco, Algiers, Tunisia, Yemen, Jordan, Iraq, Syria, all of these areas have a high incidence, age standardized incidence. We're talking about 60 to 70 cases per 100,000 per year, which is a lot. Other areas may be something around the 30 to 40 per year. If you look at the percent change, that means year by year. Since 1990 to 2017, how did things change? And it seems that we haven't changed much all in all. We're not like the US, and we're going to come to that in the global epidemiology, where the incidence seems to be decreasing per year, and that's part of the epidemiology of the disease. But at least we're not like skyrocketing or going up. Again, going back to our Arab world and focusing on it, we're talking in the ranges from 20 to 60 per 100,000 per year. That's the percent change. If you look at the prevalence of the disease, we're at the lower spectrum of the disease. You can see that the prevalence is much higher. Our area is 20 to 40 per 100,000, which is similar to Australia and Canada at the same time. But if you look at the Arab world specifically, the majority of cases, majority of areas have a low prevalence, like Libya, but most of the areas, we're talking to 20 to 40 per 100,000 population. We're going to come to the absolute numbers in a minute. Again, the change is more colorful in our area of the world, with certain hotspots like Sudan and Yemen, which is very interesting. So you see here, Sudan and Yemen, if you talk about the change in incidence change in prevalence per 100,000, we're talking in the ranges of 100 to 110 per year as a prevalence. It's going up very fast. Telling them is areas like Egypt and Jazair, as well as Morocco. And lower in that spectrum is the Gulf region as well as Libya. The quality of life, or the life years lost per population is much less. That's just because our incidence and prevalence is less. So we have a very low DALY, or disease-associated life year lost. We're talking like 0 to 10 years per 100,000 population per year. And the same thing when you talk about the change in age standardized DALYs. So let's look from 1990. Just when we talked about this is more of a Western disease, and we thought it was a Western disease, then to 2017 and the projections on what happened. So from 1990 to 2017 and the percent change in the population. We're going to look at absolute numbers and counts as well as rates per 100,000 population. And if you look at areas, let's have a look here. So hotspots look like, let's say Saudi Arabia, just for this interest of my bias. In 1990, it was estimated that we had something around 2,900 people with inflammatory bowel disease with a prevalence of something around 23, 24 per 100,000 population. If you look at 2017, those numbers are almost like fourfold. We're talking about 9,000 people with inflammatory bowel disease with a prevalence of 25 per 100,000. So you see the percent change isn't high, it's only 6%. So it's only a function of the size of the population. So the population grew in size when you had an increase in absolute numbers. Let's compare that to Yemen. So they had something around 1,000 people in 1990. Now it's estimated that they have 5,000 people. That's one of the hotspots. Let's look at Sudan. Again, it was estimated that they had 1,700. Now they have something around 7,000 people with IBD. Egypt, the same thing, 7,000, something around 1990 with a rate of something 17.9. And now it's estimated that they have 22,000 people with inflammatory bowel disease in Egypt. And that's about a percent change of about 50%. That's a lot. So these areas are becoming hotspots. So what happened? Just for us to understand the epidemiology and where we're going to go, we know that the incidence of inflammatory bowel disease has something to do with smoking, has something to do with genetic susceptibility, and we do have a common genetic pool given our racial backgrounds and our geographical areas. And there's a change in the microbiome, and that's part of hygiene. And what happens when people have improved sanitation, we move from helminthic infections, infectious diseases like tuberculosis, and you move on to diseases that are immune mediated. Again, also we have the issues of pregnancy, duration of breastfeeding, genetics, and as well as drugs and environmental factors. And drugs, we're talking about antibiotic exposure. Those have effects on the microbiome of the intestine, and as such can contribute to the development of inflammatory bowel disease. And the age of onset of the disease does have a different component. So in pediatrics, there's mostly a genetic component for early onset disease and less of environmental factors. Where we talk about middle age type of onset or young adolescents, genetics and environmental factors have somewhat of a interchangeable factor of influence on the development of disease, while IBD in the elderly is mostly it's thought of environmental exposures more than anything else. And that's also reflected again in the concept of the manifestation of the disease. So pediatric onset Crohn's has a somewhat similar distribution between inflammatory and stricturing, while in the elderly it's mostly inflammatory disease, less of a stricturing, and even much less of a penetrating disease, which might contribute to a more moderate to mild disease trajectory. The global incidence and prevalence, at least in the West, it's thought of the incidence something around, stabilized around 20 per 100,000 population, while for Crohn's it's less, ulcerative colitis maybe more, but there's an overlap definitely between CD and UC. And let's look at the epidemiology and try to understand what's happening in our geographical area. So the incidence is the number of new cases that you develop. And this was a nice paper by Kaplan, Gil Kaplan. What happens is you have more diseases, people develop the disease, they drop into the pool of the prevalence of disease, and that pool only comes out and you lose that prevalence, only decreases if there's deaths. Now with improved medication, improved healthcare, we anticipate that this mortality aspect is going to be low. So it's only, the prevalence is only going to increase till you have an aging population, then you have a decrease in the prevalence of the disease and you reach a state of equilibrium. What contributes to this increase in incidence? Either it's unmasking of disease that was always there, what we never picked up, improved diagnostics, whether it be invasive, non-invasive, your calprotectins, your endoscopies, your histopathologies. So you're unmasking disease that was always there but was never seen. Or it's real increase in incidence due to the decrease in the environmental factors we spoke of, the smoking, the diet, the microbiome, the genetics, the antibiotic exposures. All of those factors contribute to an increase in incidence of the disease. And this is what happens. So in the West, they did have an early development of incidence and emergence of disease. And thus, in the 1950s to 2000, although the incidence increased, it's mostly of a prevalence increase. And around 2020, the incidence in the West has stabilized and the prevalence is almost plateauing, and we're going to reach a state of equilibrium where the disease prevalence and incidence stabilizes and the pool is only left by competing causes of death as well as the aging population. Now, industrialized countries, and this reflects our area of the world, the Arab world, or even parts of Africa are considered developing. The new emergence of disease, we're seeing more and more incidents, it's going up, and the prevalence is going up dramatically. So we're seeing a tide of patients, but with time, we definitely are going to reach that equilibrium that the West has reached. When we're talking about a decrease in incidence, just like we saw in North America, that's what we're going to see a few years down the road. Whether it be years or decades, only God knows. And Kaplan, this is how he describes the globe as he sees it with his eyes. So he sees that the compounding prevalence or the stabilization of disease has been reached in North America, Western Europe, Australia, while our part of the world, in the Arab world, is accelerated incidence where we see more and more cases and the prevalence is going up, while other parts of Africa, part of the Arab world, are emergent areas. This is how they see it. And what's important for this alliance or this association, the PACA, and what we're trying to do today is to understand the epidemiology of the disease in our countries, the clinical manifestations, the disease course, because what we know from other publications, from other groups in Asia is that inflammatory bowel disease in the West and the East is different. We're not the same. The age of diagnosis in the West is something around 20 to 39, while in the East, we have a peak of up to 50. So we have a wider age range where we pick up the diagnoses. In the West, it's mostly female CD predominant, while in the East, it's mostly male predominant CD and UC. Again, CD is about 1/3 of the disease are stricturing, which is not seen in the West. It's mostly inflammatory, and the disease course is much less severe in ulcerative colitis in the East as compared to the West. So there are phenotypic differences and behavioral differences between the East and the West. And honestly, the publications in our Arab world are not that up to par of what was described. Some other manifestations, although we do have some stuff in common, like breastfeeding, decreased duration, contributes to the development of IBD. Having pets might decrease the incidence of IBD, and that maybe comes from the microbiome exposure of the patients who have domicile type of animals. While in the East, smoking surprisingly doesn't have that much of a contribution to the disease course. There's no association between appendectomy, let's say, and ulcerative colitis. That hasn't panned out, at least in Eastern Asian countries. The exposure to antibiotics is protective as opposed to increases the incidence of CD in the West. So there are fundamental differences between both geographical regions. And I'm gonna finish our presentation on 2 slides. And where should we see these differences? So racial and ethnic disparities in diagnosis, in treatment, do have elements in embedded genetic differences although yes, we're human beings, but we do have differences. I've seen a paper from Algeria looking at the NOD2-CART12 genetic profile of people with inflammatory bowel disease in Algeria, and there was no association between it and the development of the disease, which was interesting. And the authors of that paper thought it was like maybe related that there wasn't enough environmental exposure to trigger that genetic inheritance risk, which is also interesting. Access to IBD specialists, and I think our PAC today should work on improving access of patients to specialists in IBD, differences in insurance coverage, paying for these medications, access of patients to these increasingly expensive medications, and the phenotypic differences. All of these factors necessitate that really work as a group to try to understand the disease in our area in a much better and holistic way. Hopefully our PAC this evening and starting from today would assess the real-world data of inflammatory bowel disease in our countries, study patient-related outcomes that are important to our populations, to our patients, and might not be the same importance to Western countries or European nations. We should learn from our diversities and differences, and we should always aim to improve access of care to our patients. And I think our data revolution and the big data era that we're working on can enable us to build registries, connect our information, our knowledge, our studies together, and hopefully improve our predictive risk models, phenotypic manifestations and mapping of our patients, drug repurposing and drug development, and hopefully precision medicine. We might find that some medications work in our population better than others, and others might not do the same. So I think that's the importance of our alliance today. And with the group of talented people that you are, I'm sure that's going to be realized hopefully in the near future. So I'm going to stop our geography lesson for today, and I'll be more than happy to listen to your comments and share your knowledge and wisdom with us today.
Thank you very much.